Hello, good day. It's a pleasure being with you today to share with you my opinions about how to use daratumumab for treatment of multiple myeloma. I'm very happy and thankful to the organizers of the COMy meeting that should have taken place in Paris, but has been cancelled due to this tragic event with a viral infection. But hopefully we can get something nice out of this web presentation and discussion. So I'll move forward and show you my next slide, which is my disclaimer. And I can say during the presentation, I'll make some cross-trial comparisons, which are in fact not allowed, but I think they can be pretty illustrative anyway, and you can take it for what it's worth. I'd like to take offset in the Maya study. I think you know it. It's a comparison of lenalidomide and dexamethasone with or without daratumumab for treatment of myeloma patients, elderly myeloma patients that are not transplant eligible. So this is what I will start with. And here we have very excellent results from the Maya trial. We have at 30 months, we have a 71% progression-free survival in the experimental arm with daratumumab, lenalidomide, and dexamethasone, comparing favorably to the control arm of lenalidomide and dexamethasone, which still performed very well according to present standards. Here is the first cross-trial comparison with the SWOG trial that has paved the way for approving VRD as a frontline treatment in Scandinavia, at least, for treatment of elderly and also younger myeloma patients with newly diagnosed multiple myeloma. And you can see here from this presentation, it has also now been published as a full paper in the Lancet, that at 30 months, you could achieve a progression-free survival of 57%, which is less compared to the DAR-Lendex in the Maya trial. And also of note is the fact that 43% of the patients were over 65, and in the Maya trial, it was actually 44% of the trials that were over 75 years of age, so a much older myeloma population, much closer to real-life patients than in the SWOG study. So really excellent trial data from this Maya trial. Also for comparison, I have this first-line Maya study compared with patients from Italy that were treated with double auto transplant. This is a retrospective analysis made by Michele Cavo and presented at ASH in 2018. And you can see at 30 months, they achieved a progression-free survival of 72%, which is equivalent to what has been obtained in the Maya study with a much older patient population. So one could perhaps think that this is close to being ideal, but when you look closely into the details of the Maya trial, you can see that there are some problems here. We have in the experimental arm compared with the control arm, we have lower dose intensity of len. We have more discontinuations of lenalidomide, more delays, less dose intensity of dexamethasone. We have more neutropenias, more pneumonias, and more infections coming out of the addition of daratumumab to lenalidomide and dexamethasone. What can we do about that? I think if we want to further improve the outcomes for our patients, we should support them to avoid neutropenia, which is a common finding during this type of treatment. And I give GCSF support 2 or 3 times per week on days of lenalidomide therapy to avoid neutropenias and dose delays and dose reductions. I also use a lot of immunoglobulin replacement therapy to prevent infections. I realize that this is not very well documented in clinical trials, but anyway, in my experience, it works well. There is a recent small Italian study to support this, presented in clinical immunology, showing that there was a very, very significant difference in the number of infections and days on antibiotics when patients were treated with immunoglobulin replacement therapy and much fewer severe infections in the patient population that received the immunoglobulin replacement therapy. What about the duration of treatment? If you treat patients with daratumumab, lenalidomide, and dexamethasone, for how long should you continue? If you look back at the Pollux trial, which was similar in design to the MAIA trial, but in the relapsed refractory setting, you can see that the patients continue to improve their response, becoming MRD negative over a time period of up to 3 years. So ideally, you should continue for this time span to achieve maximum benefit from your treatment when you treat with daratumumab, lenalidomide, and dexamethasone. In my experience, many patients tend to complain about side effects coming from lenalidomide and dexamethasone, so I often can only treat them with the full combination for 2 years, and then I continue on dara monotherapy until progression. What about saving the best treatment to later on? I think that's a very bad idea, because you can see from this real-world study that the number of patients that achieve first line, second line, third line, and subsequent lines of therapy declines very rapidly. So ideally, you should give the best treatment upfront so that most of your patients can get benefit from the very best treatment you have to offer. I think you are familiar with this cartoon from the paper published in Blood by Jakob Kreisig and his colleagues, showing that daratumumab can get rid of the regulatory cells of the T, B, and M lineage, so that cytotoxic T cells become activated and expand. Perhaps less well known is the fact that daratumumab and CD38 antibodies also have a direct effect on cytotoxic T cells, so that it can boost the cytotoxic activity of T cells. I do not have time to go into the details, but have to refer you to this reference for the experimental details lying behind this notion. So a direct effect also on T cells, not just getting rid of suppressor cells and regulatory cells, but a direct effect. This is the cartoon I think you are familiar with. We have daratumumab given to patients with myeloma, and some direct effects with complement-mediated cytotoxicity, ADCP and ADCC. But then we have here the immunoregulatory part of it, getting rid of the regulatory cells. But importantly here, I would like to focus on the fact that adenosine is a product of CD38, the CD38 molecule, which is blocked by daratumumab, so the production of adenosine that is immunosuppressive is reduced, and I think that may be very important. So we can speculate, is it important? There are some interesting papers I can refer to where you can read about the effect of daratumumab and CD38 antibodies on the production of adenosine and the importance of this. And we all know the old paper on the severe combined immunodeficiency called by adenosine. So adenosine is indeed a very strong immunosuppressant. A very recent and very interesting observation came from Great Britain, showing what they had already observed in acute myeloid leukemia, but also now found in myeloma. The finding is that when the myeloma cell, the cancer cell, is in contact with a stromal cell in the bone marrow microenvironment, there's a formation of nanotubes that transfer mitochondria from the stromal cells to the myeloma cells. And this results in the fact that myeloma cells become more proliferative, more robust to cytotoxic agents and so on, so that this is really a factor that is important, and it is dependent on CD38. This is very important. CD38 is involved in this formation of the nanotubes. So if you block CD38, you block the mitochondrial transfer from the stromal cells to the myeloma cell, and the myeloma cell will be less vigorous and vital. So we can conclude that daratumumab can control myeloma by direct immune-mediated killing of myeloma cells by CDC, ADCC, ADCP, but it can also modulate the immune system by eliminating immunosuppressive regulatory cells of the T, B, and M type, and it can boost directly the activity of cytotoxic T cells. What I call metabolic effects include the inhibition of generation of immunosuppressive adenosine and inhibition of transfer of mitochondria from stromal cells to myeloma cells. So these are all, I think, important factors. This is shown in a cartoon where you'll see the CDC, the ADCP, the ADCC here, the elimination of the regulatory cells with improved T cell function, reduction of adenosine production and improved T cell function, and you'll see the reduced adherence to stromal cells with reduced mitochondrial transfer from the stromal cells to the myeloma cells and less proliferation of the myeloma cell. So in this paper we discussed is if low CD38 expression was good or high CD38 expression was better. So I think this is still an open question. So if we assume that low CD38 expression is beneficial, it's because it causes reduced adenosine production in the bone marrow microenvironment, reduced nanotube formation and mitochondrial transfer, altered adhesive interactions in the bone marrow microenvironment, and it can directly boost T-cell mediated cytotoxicity. And the implication of this is that you should continue DARA and exchange the partner to DARA at the time of progressive disease. Alternatively, one could state that high CD38 expression is beneficial because you have better CDC, better ADCP, and better ADCC, and this is well documented. And the implications here would be that if this is the important part, then you should pause DARA and allow for recovery of CD38 expression by the myeloma cell, or even stimulate CD38 expression by the myeloma cells with ATRA or panobinostat, which have been shown to have this effect. So perhaps the answer is not one or the other, but it could perhaps depend on which part of the anti-myeloma treatment you are looking at, early or late. So I am speculating that perhaps it's good in the beginning of the treatment to have high CD38 expression on the myeloma cell, because you will have more complement-mediated cytotoxicity, more ADCC and more ADCP, and you will have a rapid response in the patient with a decline of the number of myeloma cells. In the long run, later on, perhaps the immune part of the treatment and metabolic part of the treatment becomes more important when you have low CD38 expression due to the selective pressure from daratumumab. You will have reduced adenosine production in the bone marrow microenvironment. You will have reduced nanotube formation, altered adhesive interactions in the bone marrow microenvironment, and direct enhancement of T-cell mediated cytotoxicity. So it has important implications for treatment, because if it's good to have low CD38 expression by the myeloma cells, then you should continue with DARA from first line of treatment and forever until the patient succumbs to progressive disease. And you can exchange the partner at line 1, 2, 3, and subsequent lines of treatment, but still keep going on with DARA, because you weaken the myeloma cell when you keep CD38 low. The alternative viewpoint is that it's good to have high CD38 because you can better fit with CDC, ADCC, and ADCP. And then you should perhaps start with DARA in the first line. And when you have progressive disease, you should stop DARA and take another line. And if you have re-emergence of CD38 expression at a high level on the myeloma cell, you could perhaps on a third occasion at a third line of treatment, you could perhaps consider bringing daratumumab back again. So this is a kind of retreatment approach that is now being tested in a clinical trial. So we'll see what comes out of it. So when it comes to minor practical aspects, I think most of it have been solved. We know how to handle the infusion-related reactions, and we know that they will be much reduced by using the subcutaneous version of daratumumab. We know about the interference when we want to assess for CR, that the DARA can appear as an M protein and can make it difficult to ensure that the patient is in CR. We know that the blood bank can have problems with daratumumab in the serum. We know that there can be interference with flow cytometry if you use CD38 as a target, and for MRD assessment, that could be a problem. But one thing that has not been discussed so much is the possible impact of immunoglobulin replacement therapy on the pharmacokinetics and the activity of CD38 antibody. So for the infusion-related reactions, I'll pass rapidly over that. We know we want to pre-medicate and stop the treatment for a while if there is a reaction, and post-medicate, especially in patients with chronic obstructive pulmonary disease. There can be a problem with late reactions. The interference with daratumumab has been solved with a special assay where you can make a addition of a anti-idiotropic antibody to DARA to the serum, and you can see a migration shift as shown here by the arrow from here to there, and tell that this band is indeed daratumumab. Newer techniques are being developed, such as mass spectrometry, and also an assay where daratumumab is taken out of the serum by an immune adherence process. For the blood bank, you need to communicate with the blood bank before you start treatment with daratumumab, so that pre-treatment samples are being taken for the blood bank, because daratumumab will cause reactivity in the antibody screen test, the indirect Coombs test, and the cross-match test, and this will cause worry in the blood bank if you have not informed them beforehand. Also, the interference with flow cytometry can be a problem. The pathologist would like to know that the patient is receiving CD38 antibody, because you can mask the expression of CD38, and to identify the plasma cells, you can use other plasma cell markers, or you can use an antibody that does not react with the same epitope as daratumumab, and then be able to demonstrate the CD38 expression by this manner. An aspect that has perhaps attracted less attention is the potential impact of immunoglobulin replacement therapy on the pharmacokinetics and activity of CD38 antibody. So we could speculate that the treatment would affect the PK and activity of CD38. We know that when the patient is treated with immunoglobulin intravenously, there will be big shifts in the serum concentration of immunoglobulin, with peaks of IgG in the serum immediately after IV infusion of immunoglobulin for replacement therapy. There has been a study looking into the difference between patients with IgG and IgA myeloma, and you can see in the case of IgG myeloma, the clearance of daratumumab was faster than in IgA myeloma, and you can see here that the serum concentrations of daratumumab was lower in IgG compared to IgA myeloma, and this may in fact be due to the fact that in the body we have what is called neonatal Fc receptors that are protecting IgG from being degraded. And when you saturate these neonatal Fc receptors with immunoglobulin for protection against infections, you will have a more rapid turnover of other IgG molecules such as daratumumab. But this is the explanation for the differences in the pharmacokinetics and serum concentrations of DARA seen in IgG versus IgA myeloma. If it has a clinical impact, we don't know, but it should be studied in more detail. So I'd like to finish with a hypothesis that anti-myeloma therapy comes in two phases. One, first with a rapid cytoreduction, and I think for this purpose we can use all anti-myeloma agents that can kill myeloma cells. But the second important part of it is a part where we have immune-mediated and metabolic control, and here we can use IMiDs, CD38 antibodies, other antibodies, CAR T-cell bites, checkpoint inhibitor antibodies, and vaccines in order to obtain an immune-mediated control of myeloma. And I think if you don't have both in your plans when you treat a myeloma patient, the initial rapid cytoreduction and the long-standing immune-mediated control of the disease, you will not get an optimal result out of your treatment. Thank you for your attention. I'll be happy to answer questions.
Good morning. The topic of this talk is how I manage cardiovascular events in multiple myeloma for the COMy 2020. I'm Nijhof. I'm a hematologist, and I'm interested especially in multiple myeloma. I'm working in the Amsterdam University Medical Center in the Netherlands. These are my disclosures. Cardiovascular events in multiple myeloma is happening quite often. This is partly due because multiple myeloma is a disease of the elderly. The median age at diagnosis is approximately 70 years, as you know, and that means a high baseline incidence of cardiovascular risk factors, which likely enhances treatment-related cardiotoxicities. But also multiple myeloma itself is an independent risk factor for the development of cardiovascular complications and thromboembolism, regardless of treatment. And then cardiovascular complications are also associated with newer but also older myeloma treatments. And also for a subset of multiple myeloma patients, chronic kidney disease and/or concomitant amyloidosis further enhances cardiovascular events. I would like to start with a case. The first patient is a 72-year-old, newly diagnosed multiple myeloma patient with a swollen lower leg. She has an IgA kappa multiple myeloma with standard risk cytogenetics, with osteolytic bone lesions and anemia as criteria. She is treated with lenalidomide and dexamethasone, and thromboprophylaxis was given with aspirin. However, she experienced a complication. Namely, during the third cycle, there was a sudden swelling of the right lower leg with a deep venous thrombosis confirmed by compression sonography. So lenalidomide and aspirin were discontinued and low molecular weight heparin was started. 2 weeks thereafter, lenalidomide dexamethasone was restarted again. Well, already 140 years ago, Trousseau recognized the association between venous thrombosis and malignancy, also multiple myeloma. But also later on, in newer studies like a large case control study published in JAMA in 2005, this association between venous thrombosis and multiple myeloma was recognized. In this large case control study, we saw that malignancy itself increases VTE risk 7 to 10-fold. But especially hematologic malignancies, including multiple myeloma, or maybe especially multiple myeloma, are associated with a high VTE risk, so venous thrombosis event risk, up to even 28-fold, representing the highest reported risk of VTEs amongst patients with cancer. Already in the early 70s, it was recognized that multiple myeloma has a hypercoagulable state. And multiple myeloma was described as an independent risk factor for VTEs. Approximately 10% of our multiple myeloma patients treated with chemotherapy experiences VTE complications, and the median time from diagnosis to the development of VTE is approximately 8.5 months. And indeed, when you look at this graph, with on the y-axis the relative risk, and on the x-axis the time, then you can see with the dotted line, there's an average risk for VTE with cancer. But especially for multiple myeloma, at the time of diagnosis, there is an enhanced risk for VTE in multiple myeloma patients. When we start treatment after diagnosis with chemotherapy, for example, this risk even further enhances. But when the patient is responding, when the disease is going into remission, this risk is also lowering. But at the time of progressive disease, and especially at the time of relapse refractory disease with palliative care and immobilization and a high tumor load, then this risk is increasing again. VTEs have even more been observed in patients with multiple myeloma treated with IMiDs, so with immunomodulatory agents, especially when these IMiDs are used in combination with high-dose dexamethasone or with chemotherapy. In a big meta-analysis of more than 3,000 patients with multiple myeloma, it showed that thalidomide itself increased the VTE risk approximately 2.6-fold. But when thalidomide is combined with dexamethasone, this risk is even increased to 8-fold. And the same holds true for lenalidomide and pomalidomide. These incidences of VTEs can be lowered with thromboprophylaxis. How does it come? What are the reasons for an increased VTE risk in multiple myeloma and for patients treated with IMiDs? When we look at multiple myeloma itself, then the increased VTE risk is caused by multiple myeloma cells, but also by bone marrow stromal cells. So monoclonal protein-associated lupus anticoagulant, protein C and protein S deficiencies increased VTE risk in multiple myeloma, but also hyperviscosity, for example. Multiple myeloma cells and also bone marrow stromal cells produces inflammatory cytokines like IL-6, TNF-alpha, for example, and this causes endothelial cell dysfunction, platelet activation, thrombosis formation. IMiDs even further increase cytokine production. Furthermore, there's an increased expression of factor VIII and von Willebrand factor, and there's an acquired activated protein C resistance. So also IMiDs itself increase the VTE risk. When you combine IMiDs with dexamethasone or with chemotherapy, this risk is even further increased, like I said. And also concomitant use of EPO, for example, further increases the VTE risk. Is there also an increased arterial thrombosis risk? Well, indeed, patients with multiple myeloma also have a high risk of arterial thromboembolic events, including coronary artery disease and cerebrovascular disease. This is partially due to the high burden of cardiovascular comorbidities in these older patient populations, like with the VTEs. But also in the younger patients, there's a higher incidence of arterial thrombosis. Especially hypertension and also smoking are relative risk factors, which enhance this risk. Thalidomide was in a big prospective cohort not associated with increased ATE risk, so with increased arterial thrombosis risk. However, lenalidomide was, so also IMiDs might enhance the arterial thrombosis risk. So what should we do for the prevention of VTE and maybe also ATE? Well, maybe we should give these patients thromboprophylaxis. Should we give all patients thromboprophylaxis because multiple myeloma itself is also a risk factor, like we have seen? But of course, we should take into account that reduction in thrombosis with thromboprophylaxis also might increase bleeding. And indeed, that's the case. When we look at the prophylaxis with low molecular weight heparin, this is a meta-analysis for cancer patients, so also multiple myeloma patients, but also cancer patients, and it summarizes 6 RCTs. And then you can see when you treat these cancer patients with low molecular weight heparin, the venous thromboembolism risk is indeed lowered with an absolute risk reduction of 1.8%. However, the major bleeding risk is enhanced with an absolute risk increase of 1%. And when you go further into this, then the benefit might be of VTE prophylaxis with LMWH, the venous thrombosis risk, which is lowered, but the harm is the major bleeding risk, which is enhanced with 1%. And when you take into account all bleeding events, it's even higher with 2.4%. So it's not the advice to treat every multiple myeloma patient with prophylaxis. But when we go deeper into it, then you can read the consensus of the European Myeloma Network, for example, published in Leukemia in 2018, and then you can see there are different risk factors, like the patient-related risk factors in multiple myeloma, like obesity or a history of VTE or comorbidities, but also the myeloma-related risk factors like active uncontrolled disease. You have other medication-related risk factors like the use of erythropoietin, and the already discussed myeloma medication-related risk factors, especially the IMiDs, high-dose dexamethasone, doxorubicin, or multi-agent chemotherapy. The recommendation for prophylaxis from the EMN is that there is just one patient-related factor or myeloma-related factor or other medication-related factor that you can treat these patients with prophylaxis with aspirin once daily. But when there are two or more risk factors, then you should treat these patients with low molecular weight heparin or full-dose warfarin. When patients are treated with myeloma medication-related risk factors like IMiDs or chemotherapy, or especially a combination of IMiDs with dexamethasone and chemotherapy, then you should treat these patients with prophylaxis with low molecular weight heparin or full-dose warfarin. So what is high-dose dexamethasone and which comorbidities are meant? High-dose dexamethasone is more than 480 milligram dexamethasone a month, and comorbidities are diabetes, infections, cardiac diseases, chronic renal diseases, etc. So to conclude this part for EMN, but also for ASCO guidelines, the recommendation is that routine prophylaxis with antithrombotic agents is not recommended for multiple myeloma patients, but patients receiving thalidomide or lenalidomide, especially when combined with dexamethasone or chemotherapy, should be treated with prophylaxis. Low molecular weight heparin or warfarin is recommended. We should, however, take into account that this recommendation is based on extrapolation from studies, postoperative studies in surgery, and also studies in solid cancer like breast cancer. So actually, we do need randomized clinical trials evaluating antithrombotic agents in patients with myeloma on thalidomide and lenalidomide, and also to define better markers. But in our current guidelines, these are the advices to not treat every multiple myeloma patient with prophylaxis, but certainly do that for the patients on thalidomide and lenalidomide, especially when combined with dexamethasone and or chemotherapeutics. Let's go to the second case, which is a 77-year-old relapsed refractory multiple myeloma patient. This patient had an IgG-kappa multiple myeloma, and the prior lines of therapy were VMP, lenalidomide, dexamethasone, and thereafter pomalidomide, cyclophosphamide, and dexamethasone. However, now she experienced chest pain and a rising M protein level. A cardio screening showed no cardiac ischemia or abnormalities, but a CT of the skeleton showed a distal sternal fracture, explaining the chest pain, and the cause is progressive multiple myeloma. This patient was treated with radiotherapy at the sternum, also combined with dexamethasone pulse course, and thereafter carfilzomib and dexamethasone was started as a new line of treatment. However, during the second cycle, there was a rapid weight gain along with progressive dyspnea. The diagnosis of this was that there was carfilzomib-induced cardiac failure, of course after excluding other possible etiologies. The carfilzomib was discontinued and diuretics were started, and there was a complete recovery of complaints within 1 week. What about cardiac failure and carfilzomib? Well, actually, it's a class effect of the proteasome inhibitors. However, it's more pronounced with carfilzomib. That might be due to the fact, of course, that the carfilzomib binds irreversible and more potent to the proteasome. Carfilzomib causes cardiovascular toxicities. When you look at all grades, then it's in 22% of the patients approximately. 13% of the patients experience arrhythmia, mainly atrial fibrillation. 12% of the patients experience hypertension during treatment, and severe grades 4% of the patients. Heart failure is present all grades in 4% of the patients, and severe grades in 2.5% of the patients. And we should take into account that these were patients without pre-existing severe cardiac morbidity. And also ischemic heart disease is experienced in 2% of patients and in severe grade in 1% of the patients. Furthermore, 1/4 of the patients experience mild to moderate self-limiting dyspnea after carfilzomib or during carfilzomib infusion. This cause is not completely clear, but might be related to cardiovascular symptoms such as cardiac failure, as well as to pulmonary complications. Most cardiovascular events when we treat patients with carfilzomib occurred within the first few doses which are administered, so in the beginning of the treatment. Cardiovascular comorbidities, especially history of atrial fibrillation or hypertension or heart failure, increases the risk for carfilzomib-induced cardiovascular events. And there are additional risk factors like the use of corticosteroids, radiotherapy, cardiotoxic agents, and of course, concomitant cardiac amyloidosis. The pathophysiology is not completely clear. Of course, there's hypotheses, and that might be that proteasome inhibitors lead to an increase in ubiquitinated proteins, which lead to intracellular accumulation of misfolded, potentially toxic proteins in the cardiomyocytes. This leads to the activation of actin and NF-kappa B, for example, which lead to ventricular hypertrophy. And these NF-kappa B activation, together with the burden of intracellular ubiquitinated proteins, further affect the intracellular signaling, induce mitochondrial dysfunction and structural changes. And this leads to subsequently to an increase of apoptosis, necrosis, and release of cardiac troponin. So this is the hypothesis how carfilzomib causes cardiac failure. How should we manage this carfilzomib-induced cardiac failure? Well, hypertension and other cardiovascular risk factors should be controlled prior to start. During treatment, there should be regular clinical surveillance with blood pressure control and also strict normal tension regulation, so to keep the tension between normal values. Unfortunately, serial monitoring of the cardiac function by EGG or cardiac biomarkers such as NT-proBNP are of limited value in mitigating the risks. However, when cardiac failure is suspected, then discontinue the treatment and perform a detailed cardiopulmonary evaluation. And once the cardiac function is restored, then carfilzomib may be reinstalled on an individual risk-benefit profile. However, preferably with a reduced dose regimen. Here you can see it in a scheme, and this is published by Bringen et al., also European Myeloma Network paper, together with the Italian Society of Arterial Hypertension. And the advice is to do a comprehensive assessment before start of carfilzomib by history and physical examination and screening for cardiovascular risk factors. Then you should correct the modifiable risk factors like hypertension, diabetes. Then you can start a treatment, but you should monitor the vital signs, especially the blood pressure. And when blood pressure is rising, then you should withhold the carfilzomib and adjust the hypertensive therapy like ACE inhibitors or calcium channel blockers or beta blockers. If there's any dyspnea, then withhold the carfilzomib also and perform an echocardiogram and chest X-ray. And when there's cardiac dysfunction, then withhold the carfilzomib and also do an analysis, of course. If the cardiac event is not related to carfilzomib, then you might restart the treatment at the same dose or reduce the dose. But of course, when it's related to carfilzomib, then you should wait that there is a recovery to grade 1 or baseline and then reduce the dose or discontinue it. This is according to the EMA guidelines. So taking together, addressing the cardiovascular side effects due to carfilzomib treatment, withhold treatment until recovery of these complaints, reduce the dose or change the regimen. You can also change to another proteasome inhibitor like bortezomib or ixazomib. And of course, treat the cardiovascular side effects according to the cardiovascular guidelines. Then we go to the last and the third case. which is a 56-year-old relapsed refractory multiple myeloma patient. This patient had an IgG-kappa multiple myeloma, and her prior lines of therapy were VTD with an autologous stem cell transplantation. Thereafter, at progression, daratumumab combined with lenalidomide dexamethasone, and thereafter carfilzomib dexamethasone. However, she experienced progressive multiple myeloma. She is treated now with anti-BCMA CAR-T treatment in a clinical trial. This treatment was complicated by day 10 at CRS, or cytokine release syndrome, grade 2, which was treated with tocilizumab. But on day 11, there was a decompensation cordis with troponin T elevation. So we asked ourselves, what's the risk for cardiovascular events with CAR-T treatment, a new treatment option, isn't it? And is it related to CRS? This is a publication published in December 2019 and answers this question. It's the cardiovascular events among adults treated with CAR-T. When you look deeper into it, then there are 137 patients included in this trial. It's a retrospective trial. The median age of this patient was 62 years old. 2/3 of these patients were male, but most of these patients had lymphoma, 88%. Only 8% of these patients had myeloma. So the majority was treated with Yescarta or Kymriah, but also a part of the patients was treated with BCMA CAR-T in trial for multiple myeloma. But what was strikingly is that in 54% of these patients, an elevated troponin level occurred. And also in 28% of these patients, a decreased left ventricular ejection fraction was recognized. And all of this occurred only in patients with grade 2 or more cytokine release syndrome. And what also is very important, that the duration between CRS onset and tocilizumab administration was associated with these cardiovascular events, where the risk increased 1.7-fold with each 12-hour delay to tocilizumab, which is an important message, I think. So here you can see the diagram showing the results of this study. So 137 patients. Of these patients, on the left, 55 of them experienced a grade 2 or more CRS. And of these patients, also go to the left again, in 31 of these patients, troponin T was enhanced. And when you look at these patients with CRS grade 2 and enhanced troponin T levels, then almost all of the cardiovascular events happened in patients with CRS grade 2 or higher and elevated trop T levels. So there were 24 patients who had this, and there was a drop in left ventricular ejection fraction in 8 of them, and there were cardiovascular events in even 16 of these patients, so 2/3 of these patients, with also cardiovascular mortality in 6 of them. When you look at the patients who have a CRS grade 2 or higher and have no troponin T elevation, then there are almost none cardiovascular events. Just in one patient, there was a cardiovascular event. When you look at the patient with no CRS or just mild CRS, grade 1, then it doesn't matter if there was some elevation of trop T or not. There was no cardiovascular events. Most of these patients had no trop T elevation. There were some. So here you can see it again on the left. When there is just mild or no CRS, then most patients do not have a troponin elevation, but also the patient with troponin elevation, there were no subsequent cardiovascular events in the patients with no CRS or just mild CRS. But for the patient with cytokine release syndrome grade 2 or more, and there was a troponin elevation, then there was a subsequent cardiovascular event rate of 55%, so in half of these patients, also involving patients with cardiovascular mortality. Especially the patient with troponin elevation were at risk. Only the patients, there was only one patient with a troponin elevation, with no troponin elevation with a cardiovascular event, like I said. And what was really important, that when we treat these patients really early with the IL-6 receptor antagonist tocilizumab, then you can mitigate this cardiovascular risk. So to conclude for this presentation, cardiovascular complications are associated with multiple myeloma itself, but also with anti-multiple myeloma treatment, especially the thromboembolic events associated with IMiDs, but also cardiotoxicity associated with classical chemotherapeutics, but also with proteasome inhibitors, especially carfilzomib. And also new treatments as CAR-T therapy have cardiovascular side effects, especially when there's CRS, cytokine release syndrome, grade 2 or higher, and also enhanced ROT levels. Tocilizumab is a good measurement to treat these patients early. Ixazomib, daratumumab, and elotuzumab shows no significant increased cardiovascular risk. And early recognition and also intervention, but also collaborative efforts between cardiologists and hematologists are essential in mitigating these cardiovascular risks.